Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture, we're going to go through musculoskeletal pharmacology, also known in some schools as bone and joint health. Let's start with a brief pathophysiology review. First, we're going to talk about calcium. Calcium is the primary component in bone formation. Next, PTH, parathyroid hormone, increases our calcium level in the blood. It increases the calcium level in our blood, which is our serum calcium level. Calcitonin does the opposite. Calcitonin decreases our serum calcium level. Now, both of these work in opposite to the bone. So if it's bringing up the calcium level in our blood, that means it's bringing it down in the bone and vice versa. Next, let's talk about vitamin D. Vitamin D can come from our diet and it can come from the sun. It is needed for the body to absorb calcium. Two terminologies: cholecalciferol is the inactive form of vitamin D, and calcitrol, not to be confused with calcitonin, calcitrol is a drug name for vitamin D. Next, let's talk about RA. RA is rheumatoid arthritis. It's in a group of diseases called autoimmune diseases. Autoimmune diseases includes a ton of diseases such as lupus, rheumatoid arthritis, Hashimoto's thyroiditis, celiac disease, and so much more. Next, we have osteoarthritis. Osteoarthritis is the most common type of arthritis. And this, we're going to learn, doesn't have a pharmacological treatment. It's actually treated surgically. Next, we have gout. Gout is a buildup of uric crystals in the joint. And this is also another type of arthritis. It's called gouty arthritis. This is not an autoimmune disease. Osteoporosis is a disease caused by a decrease in bone mass. Most responsible for this is a decrease in calcium in the bones. Calcium and vitamin D are almost universal recommendations to both prevent and treat osteoporosis. DMARDs, or disease-modifying anti-rheumatic drugs, are a major drug class, and they work to slow the progression of the disease. They do not cure any condition, but they slow the progression of disease, and almost always they also manage the symptoms as well. Whenever we're talking about anything in this video, and in almost everything in pharmacology for that matter, we're always going to start with non-pharmacological interventions. Let's begin with rheumatoid arthritis. We're going to have three first-line drugs for rheumatoid arthritis, and depending on what the provider's preference is of which one they're going to be starting with. Now, these are the prescription medications. Very often when patients have RA, they're first going to start with NSAIDs. That would be ibuprofen, something like that. Please keep in mind, this is an inflammatory disease. So if a patient asks you, what's the best over-the-counter pain medicine, your answer should always be ibuprofen, not acetaminophen, because acetaminophen, Tylenol, does not have anti-inflammatory effects. Ibuprofen, which is an NSAID, does. So patients are very often going to be on NSAIDs, generally for quite a long time before they actually even get the diagnosis of rheumatoid arthritis. Once they get that diagnosis, and this is usually done by primary care or more often by a rheumatologist, they're going to be put on one of three medications: methotrexate, 5-aminosalicylate, or hydroxychloroquine. Let's go through each of those. Methotrexate, you may recognize from other videos, because methotrexate is also used to induce abortions, and it's also used for cancer. Methotrexate has a number of different ways that it works. We don't know how exactly it helps for rheumatoid arthritis. We talked a little bit about the different indications for using methotrexate. Methotrexate, along with all DMARDs, takes several weeks until they take effect. It takes several weeks until the patient starts to see relief. It is often a first-line drug, but again, these are relatively equal in first-line aspect in terms of depending on the preference of the rheumatologist. Methotrexate is absolutely teratogenic. It cannot be given in pregnancy. It does have pretty major side effects, which is why to some rheumatologists, this is not their preferred drug. Next, we have the 5-aminosalicylate, 5-ASA. This drug is not as common as methotrexate and hydroxychloroquine, but it is another option. The mechanism of action is that it reduces inflammation. It's used for ulcerative colitis and for RA. It does have two adverse effects. One is GI effects, and one is blood dyscrases. The onset of action, again, is still going to be several weeks, and same for the next one. Hydroxychloroquine. This is actually an anti-malaria drug, and we discussed this in our infectious disease lecture. This drug is also used for autoimmune diseases such as rheumatoid arthritis. Again, this is considered a DMARD, and it takes several weeks till it takes effect. One thing that is commonly tested on this is the fact that it requires an eye exam because it can be toxic to the eyes. Next, we have the next step up. So far for RA, we talked about non-pharmacological interventions. Actually, we didn't, but there are non-pharmacological interventions for RA. things like stretching and things like that. Next, we had over-the-counter, such as NSAID, specifically ibuprofen. And I should also mention here another NSAID that is often used, this one's by prescription for RA, and that is celecoxib. Celecoxib or Celebrex is an NSAID that is used specifically for RA, and it is a COX-2 only inhibitor. We discussed this in detail in the anti-inflammatory lecture. Then from there, we went to DMARDs. DMARDs is generally where a patient will get what a patient will get once they've been officially diagnosed with RA and they're being managed by a rheumatologist. And that's where we said it's going to be either methotrexate, the 5-aminosalicylate, or hydroxychloroquine. And those are all called DMARDs, and those all take several weeks to work. They're all pretty aggressive drugs, and they all have side effects. Moving beyond that, we have the monoclonal antibodies. These are the ultimate, the best drugs to treat RA, but these also have the largest amount of side effects and issues. First of all, they're very expensive. Second of all, they're by injection only. Third of all, these medications suppress the immune system. So that means the patients at increased risk of fevers. And fourth, if that's what we're up to, this drug also it takes several months to get the full effect, the full benefit of the drug. All that being said, these drugs work extremely well at managing symptoms and slowing the progression of the disease. These are still considered DMARDs, but these are a more complex type of DMARD. These are biologic DMARDs, but the drug class here is monoclonal antibody. The drugs we're talking about, you probably recognize some of the brand names such as Humira. Fun fact, Humira is the most profitable drug ever, up to this point, at least in mid-2025. The mechanism of action is that these are biologic agents, and we're not going to go into detail in any of the monoclonal antibodies and how exactly they work. It's very complex, and it's not tested on in RN school. What do we use monoclonal antibodies for? Well, today we're talking about autoimmune, specifically rheumatoid arthritis. However, monoclonal antibodies are used for dozens of different conditions. In fact, there are over 100 different drugs in this class. They're used to treat cancer. They're used to treat high cholesterol. They're used for asthma, COVID-19. Not COVID-19. They're used for digoxin reversal, asthma, and so much more. Next, these drugs do have a black box warning that they can cause cancer and that they can cause serious infections. That's where I said it's an immunosuppressant. These drugs are given by injection only, almost all of them. I'm told there are some exceptions. I don't know exactly what those are because all the ones I'm familiar with are by injection only. That's why I put it here. The onset is several months, as I mentioned, and this is a DMARD, as I mentioned. That was rheumatoid arthritis. Let's move on to gout. Gout is technically gouty arthritis. This is not an autoimmune disease, but it is a type of arthritis. And one of the drugs we're going to learn about is colchicine. So let's back up a second. When a patient is having an acute gout attack or gout flare-up or gout episode, whatever they want to call it, we have three options for how to treat it. We can treat it with NSAIDs, we can treat it with steroids, and we could treat it with colchicine. Those are the three options: NSAIDs, steroids, and colchicine. Colchicine, let's learn about that because NSAIDs and steroids we've already covered elsewhere. The mechanism of action of colchicine is that it blocks neutrophils that are associated with the buildup of uric acid that causes gout. The indications for this is obviously gout, and that's all we use this for. The adverse effects of this is that it can cause some GI issues. This does have a narrow therapeutic index, so we have to be very careful with our dosages. And like I said, the other options to treat a gout flare-up are NSAIDs and steroids. Now, do keep in mind, these are generally considered equivalent first-line options. Depends on the patient, depends on the provider, what they're going to do. I do also want to point out steroids, when they're given in this case, it may be given PO, or it may be given a direct steroid injection into the site of the gout flare-up, which is almost always going to be the big toe of the patient. Now, I will also tell you, and this is just a fun fact, you don't need to know this at the RN level, the direct steroid injection into the site of the gout attack is preferred over systemic steroids only if the provider, the doctor or nurse practitioner taking care of them, are very good at those injections. If they're not comfortable with those injections, then we prefer to give them PO steroids as opposed to the injection steroids, because generally we like to be as narrow, as focused, as localized as possible. So that's why we prefer the injection. But if they're not good with it, the recommendation is to actually just give it PO. Anyways, off track. Next. So we had three medications for an acute gout attack. That was NSAID, steroids, and colchicine. And we talked about two different ways to give steroids. Now let's talk about someone who gets these gout attacks pretty frequently. The usual number we use is more than 2 a year. So if a patient's getting frequent gout attacks, then we may switch strategies. And instead of waiting until they develop attack and treating it, we may just put them on a daily medication and hopefully they never have an attack again, or at least it goes tremendously down in how often they have them. We have three options for what medications we can use to prevent gout attacks. Number one is colchicine. It's at a different dose than if the patient had an acute gout attack, but this one is the one medication that's used both to treat a gout attack and as a daily medication to prevent gout attacks. Then we have two others, and these are the more common ones used today: allopurinol and probenecid. Let's start with allopurinol. The drug class is xanthine oxidase inhibitor, and this reduces uric acid levels. We use this for gout prevention. We also use this for nephrolithiasis, which is kidney stone. The onset is several days, and it peaks at about 1 to 3 weeks. The adverse effect are SJS, so make sure you're assessing their skin for that developing. And this one, allopurinol and probenecid, unlike colchicine, cannot be started during an acute attack. And patient education, take it with food. Next, we have the uricosurics. The drug over here is probenecid. This one does the exact same thing. It reduces the uric acid level. And again, it's used for the same thing for gout prevention. And again, the same thing, don't give it during an acute attack. Patients who do have gout, you do need to educate them to avoid the triggers of their gout attacks, such as alcohol or certain dietary items. Next, we have bisphosphonates. Bisphosphonates, the drugs in this class are alendronate, ibandronate, zoldronate. These are all different bisphosphonates. These drugs decrease bone turnover and increase bone density. So they make your bone stronger. So they're used to treat what? Osteoporosis, which is a weakening of the density of the bones. So we use this for osteoporosis, also for Paget disease, which is another bone and joint disease. Bisphosphonates are the first-line treatment for osteoporosis. They do have side effects of causing GI effects, a metallic taste in the mouth, and low serum calcium because they're using up so much calcium to fortify the bones. Zoldronate specifically is the first-line drug for Paget disease, according to most of your textbooks. I have seen otherwise, but I put it in there because that seems to be pretty common. These drugs are not recommended to be taken in pregnancy. They do have two interesting patient education, so you do need to know them because we like putting those on tests. Number one is that it should be taken on an empty stomach with a full glass of water. And number two is patients should stay upright in a sitting position for 30 minutes following administration. They should not lie down flat after taking it. Don't ask me why. I do not know, and I am curious about that. Next, any patient who's been treated for osteoporosis, I mentioned this at the beginning of the lecture, they should 100% be recommended to take calcium and vitamin D supplements. Next, we have our SERMs, selective estrogen receptor modulators. The drug over here is raloxifene, and this one works similar to estrogen. What is this used for? To treat and prevent osteoporosis, specifically in postmenopausal women. Again, if we're talking about osteoporosis, make sure the patient is supplementing with calcium and vitamin D. Because this is estrogen, it is teratogenic. And because it's estrogen, it has the same black box warning as regular birth control, that it has an increased risk of developing clots. Lastly, let's talk about calcium. Calcium, all of this was covered in the fluid and electrolytes lecture, so I'm going to go through this pretty quickly. It's available PO and IV. I'm not going to get into all the details over here. It is on your screen. Hypocalcemia, signs and symptoms. Hypercalcemia, signs and symptoms. This does come in a lot of different formulations. They're not interchangeable, so make sure you're paying very close attention, especially on tests, to know the different types of calcium that are available, and make sure that if a patient was ordered specifically to take one, that they, especially if there's something they're buying over the counter, that they grab the correct one and that that's what they're taking. Finally, we have calcitonin. Calcitonin is a drug that we have, and this is similar to the body calcitonin. What did I mention at the beginning of this lecture? I mentioned that if a patient has a low calcium level in their blood, their body produces PTH, parathyroid hormone. If they have a high calcium level in their blood, their body produces calcitonin. Well, we have the same thing. If a patient has a low calcium level, what do we treat them with? Not parathyroid hormone. We treat them with calcium. Think simple. We treat them with calcium. But if they have a high calcium level in their blood, we treat them with calcitonin to bring it down. Mechanism of action is it increases calcium excretion, meaning it gets rid of more calcium to bring it down. It also decreases how much calcium comes from the bones into the blood. What do we use this for? We use it for high calcium. We also use it for post-menopause osteoporosis because it'll shift some, not really shift, but it'll make the bones hold on to their calcium better. And also for Paget disease, this medication is parenteral. It's also available intranasal. If you have any questions, please reach out. Here are your references. Hope you enjoyed this video. Have a great day.